Next up, we have, yep, sorry, I was waiting for them to finish clapping. We have Justin West. He's going to be talking about SMiLE, advanced lipedema reduction surgery technique. He's in private practice in Beverly Hills.
Thank you. So the technique we're going to talk about today really was born out of what we thought were some shortcomings with the outcomes that we were seeing. So we were having some patients come in with really impressive improvement or reduction in pain and improved mobility. But then there was a subset of patients where they were having persistent pain. And we would examine these patients and oftentimes find residual nodules. So the question was, are those nodules that are new, or are those nodules that we left behind? Given that the distribution of those nodules was pretty focal, the thought process is, well, we're leaving those behind. So then the question became, should we be being more aggressive with liposuction, or is there any other adjunct that we can add to try to get a more effective removal of those nodules? Disclosures, I'm a consultant for Nasus Holdings, which has a vertical in the pharma industry, but not in this space. We've seen lots of pictures like this, but this is what we're focused on. So, below the skin, what we're looking at is these nodules. And the way we're still thinking about it in our practice is that it's important to remove the nodules. As we evolve in understanding the disease, maybe that shifts. But for right now, we tend to focus on how can we really eradicate those nodules. So we've started shifting the way we think in terms of, our original treatment approach was liposuction, really try to get out as many of those nodules as we can so that we have the sense that it's all been eliminated. Now we think of it as sort of an adjunct or part of an approach to get out the nodules. We've turned this concept, at least within the office, the way we refer to the technique that we're using is this SMiLE approach. And that breaks down to a few different steps. So what we think about is softening up that tissue, mobilizing those nodules. Then we perform the same liposuction that we've always performed, and then we add this step at the end that we refer to as extraction. So we typically use a warm tumescent fluid so that we can address some of the issues that people have with hypothermia. We then typically use exploded tip cannulas, which have this sort of a little flared tip. I'm assuming a lot of the surgeons on stage use those techniques. And we try to break up the soft tissue connection between those nodules. And this is actually the same technique that we would apply for a lot of us in cosmetic cases as well. So you can just see what we're using is that's the power-assisted liposuction handle. And we're running, we use these angled tips, and we run it through to soften up the tissue. And you can see as we're doing that, we're actually not on suction right now. We're not actually using the suction aspect of liposuction. We're just pushing the cannula in and out to try to separate those compartments, and we often see these nodules spontaneously sort of come out of the treatment area. So after we put in the tumescent and we soften the area, we then move to sort of what we call the mobilization. So while we're waiting for the epinephrine effect to take place from the tumescent, we just sort of massage gently the tissue, one, in an effort to sort of distribute that tumescent as broadly as we can, but two, to try to soften up the interconnections between those nodules to see if we can induce some separation. And what we find is that sometimes when we're doing that, you can see some of these nodules start to come out, which I hope you can see. Yeah, you can see the video. So you can see those lipedema nodules start to get expressed, and this is before we've actually started the liposuction part of the technique. And what this will sometimes do is give us some insight. Are we dealing with really small nodules? Are we dealing with bigger nodules? I think for a lot of the smaller nodules, you can treat it pretty effectively with liposuction. As the nodules get bigger, and I'll show you a video that kind of explains this, I think it's a little bit harder to get all that tissue out with liposuction alone, at least in our practice. So, we refer to lymphatic sparing liposuction like a lot of folks do. We talk about just targeting the nodules that are immediately just above or below the superficial fascia, and that really targets those superficial nodules. Somebody has added some interesting animation to our video to show the unhappy fat traveling to its new home before it gets packaged for its final destination. So then we get into the extraction phase. So after the liposuction is complete and we have the sense that we've effectively gone through that treatment area, we then apply manual pressure, depending on the circumference of the leg. Sometimes it's sort of like almost a Zamboni approach where you're just sort of pushing with one hand. Sometimes we're squeezing the entire extremity, and we try to drive those nodules towards those openings that we've made. And what you'll see is this is post-liposuction. Ordinarily, we would have been done at this point. So the way we apply our technique, we would have said, hey, we're done. We've done everything we can effectively. And then what a lot of surgeons will do after cosmetic liposuction and this surgery as well is we'll sort of drive out that fluid so that because we put a lot of fluid in the beginning of the case and it'll stick around. So we'll often sort of move the fluids out so that patients have less swelling after surgery. When we do these cases, we don't see a lot of fluid come out, but we actually quite usually see in almost every case quite a few of these nodules come out. So I think that partly explains why we're seeing further improvements in patient pain is we're using the lipo to get out a large part of those nodules, but then driving out the rest manually. We typically can't get them out through the very small incisions that we make when we add the fluid. So we actually increase the incision site at the end of the case after the liposuction. We'll take a few of those incisions in the focal areas where we're still feeling nodules, open them up and drive out more of the nodules like you're seeing there. These are pretty small. We probably could have continued to do liposuction and addressed a lot of that, but some of these nodules are pretty big. So that's a pretty hard nodule, I think, to really get out effectively. So you can say 100% of that tissue is gone just with liposuction alone. You can see that these are pretty firm nodules. It's not a typical physiological fat. So this is a video that I think from a case we did about 2 or 3 weeks ago, and I think it really demonstrates the problem that we were having in our practice, which led to the evolution of this technique.
So I want to show everybody, this is a large lipedema nodule we got out of somebody. And when I tell people liposuction doesn't get out the nodules, this hole right here is the liposuction cannula. Went right through, but didn't get out the lipedema.
So I think what happens in some of these larger nodules is you spear it over and over, but it's really hard to first of all, we can't see anything. You're doing it by feel. But I think the thought process is these are the nodules that we believe we were leaving behind for those patients who were coming in post-treatment and still having focal pain. So by doing the liposuction and then ending with the expression, we're seeing more and more of those nodules come out. So you get a sense for the deflation that you can get. This is somebody who's partly treated in that left lower extremity. We still have to go back and clean up some of those areas, but that's after both a combination of liposuction and the manual expression. So for us, I think for all surgeons, the technique that you use as an individual is key. Different things work for different surgeons, and techniques tend to evolve over time. As long as you're following your outcomes, seeing what's working and what's not working. When it's working, you don't change anything. When it's not working, you keep evolving. So this is the results we've seen. We talked about these in our previous slides, and that's if you need to get in contact with any questions, that's how you can find us. Thank you.
Thank you. Excellent presentation, Dr. West. BMI limit for you?
No, we don't have one. Typically, it's one of many factors that we look at. We really rely on clearance, making sure we have got patients who are optimized, overall good candidates. It's something that's part of the algorithm, but we don't have a hard stop at a given number.
Okay. And also, you mentioned superficial lipedema nodules. And Dr. Shapiro mentioned that most of the nodules were deep. So
Right.
kind of where, I struggle with this too, where really is the lipedema? Where should we be focusing? Treat everything, just deep, a little bit more superficial?
I mean, I think maybe in an ideal world, you would get, imaging on every patient to get a sense for what is the distribution of this patient. It'd be interesting to image 1,000 patients in a row and say, hey, what is the distribution? In some patients, is it superficial? In others, is it isolated deep? Or are you seeing a mixed bag from patient to patient where some is superficial, some is deep? Some of the thought process is using the same approach for aesthetic cases where, going above and below the superficial fascia. I think that our sense is that there's some above and below, but, we don't have ultrasound proof to really demonstrate that. So I think that the future is, can we continue to define that distribution? And that's something that I think that we're all going to benefit from looking into further.
Thank you.
Yeah.